Hello and welcome to the topic Congenital Immunodeficiency Syndromes in the module Immunology. In this module, we will be discussing the B-cell immunodeficiencies, T-cell immunodeficiencies, mixed immunodeficiencies, and congenital complement deficiencies. Let's get started. Let's discuss the types of immunodeficiencies. B-cell immunodeficiencies are B-cell defects or humoral immunity deficiencies which account for 50 to 60% of all primary immunodeficiencies. These include Bruton A gamma globulinemia, selective IgA deficiency, and common variable immunodeficiency. T-cell immunodeficiencies are T-cell defects or cellular immunity deficiencies that are responsible for 5 to 10% of primary immunodeficiencies, and these include the George syndrome. The next type is mixed immunodeficiencies, which include severe combined immunodeficiency, Wiskott-Aldrich syndrome, and ataxia-telangiectasia. And lastly, congenital complement deficiencies, which include C1 esterase inhibitor deficiency and terminal complement deficiency. We have also the phagocyte deficiencies, which are characterized by impaired ability of phagocytic cells to kill pathogens, and these account for about 10 to 15% of primary immunodeficiencies. These include chronic granulomatous disease, leukocyte adhesion deficiency type 1, and Chidiac-Higashi syndrome. Let's look at neutrophil disorders. So these are disorders that may be classified according to which component of the immune system they affect. Examples are chronic granulomatous disease, Chidiac-Higashi syndrome, and leukocyte adhesion deficiency. B-cell disorders, as explained earlier, example common variable immunodeficiency, Bruton's congenital A gamma globulinemia, and selective immunoglobulin A deficiency. T-cell disorders such as the George syndrome with an underlying defect of 22q11.2 deletion and failure to develop the third and fourth pharyngeal pouches. Combined B and T-cell disorders, severe combined immunodeficiency, ataxia-telangiectasia, and Wiskott-Aldrich syndrome. Let's look at them individually. Selective IgA deficiency is the total absence or severe deficiency of immunoglobulin A. Serum levels are usually less than 0.05 grams per liter. It's the most common primary antibody deficiencies with an unknown cause. It occurs more frequently in first-degree relatives. Features include most of the time they are asymptomatic, but they may come in with recurrent infections such as otitis media, chronic rhinosinusitis, and pneumonia, as well as chronic diarrhea. To make a diagnosis, you need to measure the serum IgA levels, which will usually be low, with normal IgG and IgM levels. There is no specific treatment for selective IgA deficiency. Prophylactic antibiotics can be given. Intravenous infusion of IgA is not recommended because the risk of anaphylactic reaction is there. Next, common variable immunodeficiency. It's more common among females as compared to males. There's an immunodeficiency arising from B-cell dysfunction. However, the B cells are phenotypically normal and can be acquired in young adulthood. There are three key features to be remembered, which are the presence of hypogammaglobulinemia of 2 or more immunoglobulin isotopes, recurrent sinopulmonary infections, and impaired functional antibody responses. In physical exam, you'll appreciate generalized lymphadenopathy and splenomegaly, and this condition is associated with increased risk of autoimmune diseases, alopecia areata, and granulomatous diseases. As for the investigations, quantitative low levels of immunoglobulin will be seen. All immunoglobulin classes will be low, especially IgA and IgG. Flow cytometry shows normal B and T cell subsets. Lymph node biopsy is done to exclude malignancy. As for management, intravenous immunoglobulin replacement therapy is the first line, and the best option would be best to prevent recurrent chest infections. Prophylactic antibiotics is given, and vaccinations are given. With patients with common variable immunodeficiency, they would usually receive killed vaccines for prophylaxis against infections. Next, severe combined immunodeficiency disease. It's the combined B and T cell disorder causing immunodeficiency with multiple variants found. Most common is X-linked defective common gamma chain and autosomal recessive adenosine deaminase deficiency. Most patients present before the age of 3 months. Without intervention, SCID usually results in severe infection and death in children by the age of 2. Recurrent infections, diarrhea and dermatitis, and failure to thrive. To make a diagnosis, there's reduced lymphocyte count, chest radiography with no thymic shadow, and flow cytometry will show absent T cells or abnormal function of B cells. Next, DeGeorge syndrome. It is a primary immunodeficiency disorder caused by T cell deficiency and dysfunction. Results from the maldevelopment of thymic epithelial elements derived from the third and fourth pharyngeal pouches. It is an example of a microdeletion syndrome, and the gene defect mapped is to chromosome 22q11. Features include risk of viral and fungal infections, parathyroid gland hypoplasia, thymus hypoplasia, cardiac defects, facial abnormalities, chest X-ray showing absent thymic shadow, and low levels of serum calcium and parathyroid hormone. Wiskott-Aldrich syndrome causes primary immunodeficiency due to a combined B and T cell dysfunction. It is inherited in an X-linked recessive fashion caused by the mutation in the WASP gene. Features are recurrent bacterial infections, eczema, thrombocytopenia, humoral immunodeficiency, autoimmune disease, and hematological malignancy. Complement deficiencies. Complement is a series of proteins that circulate in the plasma and are involved in the inflammatory and immune reaction of the body. Complement proteins are involved in chemotaxis, cell lysis, and opsonization. C1 inhibitor protein deficiency causes hereditary angioedema. C1q, Rs, C2, and C4 deficiency causes immune-coupled disease such as SLE, Henoch-Schuylen purpura, and vasculitis. C3 deficiency causes recurrent bacterial infections and hemolytic uremic syndrome. C5 deficiency causes Lehn's disease and recurrent diarrhea. And C5 to C9 deficiency causes Neisseria meningitidis infection. As for the diagnosis, you need to do a CH50 assay screening test. IgG deficiency. In IgG subclass deficiency, the overall level of IgG may be normal or slightly reduced. IgG2 deficiency causes increased susceptibility to infections of polysaccharide-coated bacteria, including Haemophilus influenza. And if these patients are vaccinated with pneumovax, they are still unable to mount a response to Streptococcus pneumoniae antigens. IgG3 deficiency leads to increased susceptibility to infections with Moraxella catarrhalis, causing frequent chronic sinusitis. We have come to the end of this topic. Thank you.